It's good to see you all. For those of you who I don't know, I'm Ndidi Unaka, and I'm so glad to introduce our Grand Round speaker for today, Dr. Michael Alice Moga. She joined Stanford in November of 2024 as the medical director of the CICU. She completed her pediatric residency at Mass General and her fellowship in cardiology at Cincinnati Children's, and then went on to complete a critical care medicine fellowship at the Hospital for Sick Children in Toronto. She then joined the faculty in the ICU and the PICU at Lurie Children's. And during that time, she also completed a master's in healthcare quality and patient safety at Northwestern University. She then came back to Sick Kids in 2015 and received a global executive MBA in healthcare and the life sciences at the University of Toronto in 2021. Her non-clinical focus is innovating our approach to quality and safety by changing work as done and creating people-centered learning health systems that improve the human experience of medicine. So welcome, and really excited to hear about your talk.
There we go. Excellent. That was the first test. So thank you everyone for coming. I am very excited to be here. In particular, not just for Pediatric Grand Rounds, but as part of this celebration month for women in medicine. So we're going to have three main objectives in the next hour or so. First, I want everyone to understand the evolution of quality in the context of the 5 industrial revolutions. We are at the very beginning of the 5th industrial revolution, believe it or not. Then you'll be able to identify core principles of quality 5.0, and then an agenda for health quality 5.0 within that. And then what I really want to leave you with are practical strategies and tools that you can then adapt to transform this work as done to improve how we experience medicine and how our patients and families experience the care that we deliver. So first of all, this will take you back. I don't even know if people remember when these things, to be honest with you, but the first industrial revolution was way back in the late 1700s. And it was all about taking this agrarian society, bringing it into cities and manufacturing. The focus there was really on efficiency. About a decade later, we actually bridged into the 2nd industrial revolution. This is when electricity became easily available, water, coal, all of these things that made these factories be able to run. Now, fast forward another decade, you can see we're kind of at a regular cadence in the beginning here. And we really reached the 3rd industrial revolution, which focused on automation. This is all about computers, machines, doing more without the humans having to do all of the things. And then now you're seeing all of a sudden, it's not just a decade later. Now in just 40 short years, we bridged into the 4th industrial revolution, which is all about digitalization. This is about the cloud, AI, machine learning, all these things that we're currently talking about as the ways now how we do work. Now, interestingly, quality of that work that was being done and the ability of people to do that work lagged behind significantly. So we didn't even really start thinking about the quality of what we were producing until well into the 2nd industrial revolution. Then it was all about inspection and control. Can we make sure that we're producing the right things? Quality 2.0 then came up a little bit later, but you see it's still lagging behind. Right around the time that we were transitioning into automation, we were just starting to think about the process of what we were doing and making sure that we weren't just making the right things, but that we were doing it in the right way. Total quality management then came up right in the middle of these 3rd to 4th industrial revolutions. And then we started thinking not just about the things and the processes, but the organization as a whole. And how are these organizations created in a way to enable the processes to make the right things? And then as you see now with Industry 4.0 coming up just in 2010, we finally have reached that quality 4.0 landmark, and that we're kind of catching up a little bit here. Lagging behind, but catching up. So now we're not just thinking about the organization and the process and the product, but we're thinking about the customer. We're thinking about the patient. We're thinking about the family. And we're thinking about how are we actually getting the things that we need to do the things that we need to do. Now, Quality 4.0 really is more than just a technology upgrade. It's all about data-driven quality assurance, but this Internet of Medical Things and this integration of what's called the cyber physical system. So how do we bring the cloud and all these things that you imagine swirling around down into the physical systems that we work in every day? It's about the interactions between humans and these machines in real-time collaboration. QI practitioners, which I will venture to you, every person in this room should think of themselves as a quality improvement practitioner. You don't have to have quality improvement in your title to practice quality, but we need to think about things differently. We need a completely new digital literacy, and we need new competencies, but we're collaborating with different people. We're collaborating with data analysts. We're collaborating with data scientists in order to be able to advance this quality 4.0 agenda. Executives need to see quality in a very different way. It is an enabler of operational excellence, and we all need to be focused on that operational excellence. But it also allows us to innovate the services that we deliver. Innovation isn't just technology. Innovation isn't just research. It's in how we deliver the care that we deliver every day. Organizations need to shift. We need to become a bit more agile, and we need to advocate for more transparency. And quality isn't just a control function. It's not just making sure we're doing the right things, but it's actually a discipline. It's a strategic discipline that lets us get to where we need to go as an organization. So as we kind of came to a head in 2018, there were 3 major reports that were released that really looked at the state of healthcare quality on a global level. You can see lots of heavy hitters created their own individual reports, everything from the Global Health Commission for the Lancet to the WHO, the Organization for Economic Cooperation and Development in the World Bank, and then the National Academy for Science, Engineering, and Medicine. Now, a group looked at all these reports, did some text mining and content analysis to reveal what the overall common themes were in these 3 major reports. And this is what they found. So to orient you, each big colored bubble is a theme that came out in the content analysis of these 3 reports. And the name of that theme is in capital letters. The small dots within each colored bubble represent sub-themes within that. And you can see that they're connected in certain ways. So the things that really came out of these 3 reports as a whole is that we still need to work on better measurement. We need to work on improving that through better communication and information technology. We need to take more of a global systems view of the care that we're delivering, and we need to have continuous quality improvement of these supporting systems for the care. We need to advocate and advance this concept of a learning health system, and this needs to be the foundation of effective research and ongoing evaluation. And at the end, their comment was, well, it's 2018 and we need to move on to the 2020s, which they said was going to be the decade of action. We are halfway through the 2020s, and I want you to think about it a little bit if you think this actually has been the decade of action so far. They called for 3 big interventions that they thought would be able to move quality and safety forward on a global level. One is creating blueprints for change that were adaptable to each healthcare context and each local kind of group. They called for taking real steps to solve the inequities in healthcare, including redistribution of resources. And then the third thing was that we needed to not just learn from when things went wrong, but we needed to learn from how things go right and make that happen more frequently, and then learn from the mundane as well. So fast forward a little bit, I doubt anyone here is going to know who this man is. This is Andre Picard. He is a healthcare reporter for the Toronto Globe and Mail, and he's been reporting on healthcare in Canada and beyond for decades. And so he had a pretty damning assessment of the Canadian healthcare system a couple of years back. Remember, we are now solidly into the decade of action. So his assessment was that, well, we're trying to deliver this 21st century care with a 1950s model of delivery and funding. It's essentially an Edsel, but we need a Tesla. I figured that would speak to this group a little bit here. The healthcare system has lurched from crisis to crisis. We're not getting the value for the money that we're spending. Even though he was saying this in the context of the Canadian healthcare system, I think this resonates a lot with the US healthcare system, and to be honest, pretty much every healthcare system in the world right now. And this is despite all of these amazing things, all of these amazing technologies, AI, this Internet of Medical Things, big data, all the things that you see on billboards and that you see programs being developed for. So why is that? Why have we not been able to capture the potential of these technological advances? I would venture that it's because we have a lack of connection. So historically in medicine, academic medicine in particular, we've oftentimes functioned in buckets and silos. So we have a very robust infrastructure around discovery and research. I would say this is how we bring answers into the care that we're delivering. About 25 years ago or so, quality improvement really started coming to the forefront in medicine. And so this is a group that we actually have to understand the problems as they exist in the care that we're delivering. Now, in the heart of Silicon Valley, everyone thinks innovation is the answer to all of this. Everyone wants to be an innovator. But I would venture that innovation actually is not sustainable from a system and a person-centered standpoint. You can't be innovating all the time. What you need to do is capture that innovation and bring it into the care as we're currently delivering it to create the new status quo and go forward from there. And so you see another quote from Mr. Picard. I would alter this a little bit. I think we don't have an absence of answers, but they don't become solutions until you actually fix a problem. And I think we're not fixing the problems that we need to fix. I don't think we lack the courage to implement them. I think in many ways we lack the ability to implement them. I do agree, scaling up and stopping perpetuating our failures. I think a lot of the problems that we face in healthcare are structural and administrative in nature. It's not that we don't have the right tech. It's not that we don't know what to do, and it's not that we don't have enough money. It is a bit of an attitude problem, but I'd venture it's a problem in approach, and it's a problem in making these key connections between that work is done and between these discoveries. Because this is essentially a snapshot of the growth of quality improvement and the different approaches in healthcare. So we've gone from maintaining the status quo through to continuous quality improvement. That's the buzzword that we all have now. If we find ways to actually connect discovery with this continuous quality improvement framework, that's how we amplify performance, that's how we create value, and that's how we create positive impact. So those of you that were paying attention so far, you notice that I only mentioned 4 industrial revolutions, but in the beginning I said there were 5. So things are speeding up even quicker now. We've quickly moved from this era of digitalization back now to an era that's a little bit more human-centered. We're entering in 2020 the area of personalization and humanization. There are 3 major pillars to this 5th industrial revolution. It's all about being people-centric. Humans are no longer just cogs in this vast machine. It's about resiliency. It's about being able to adapt quickly in order to stay ahead of the curve of this rapidly evolving system that we're within. And it's about sustainability. Do people have the skills and the tool sets that they need to operate in this completely new environment? But in addition, it's about creating these circular processes that leave things better than when we came into it. We need to leave things better for the future generations. And so a matching agenda for health quality was advanced by Leslie Thompson. Leslie is a Canadian executive, but she also is the head of the Health Standards Organization and Accreditation Canada. So that's the equivalent of JCO in Canada. And so she advanced a multi-point agenda for health quality, which is bringing safety back on the front burner. Harm certainly has not gone away, and there's, in some instances, it's been demonstrated that there's actually more harm happening today than there were a couple decades ago. It's about tackling this global workforce crisis in healthcare, advancing a co-creation agenda, creating solutions with, not for people. Access for all, tackling planetary health. Now that's a big part, that's a big thing to tackle. People advance and think that the number one thing that's affecting health currently is the health of the planet. And then rebuilding trust and confidence. This isn't just making sure that patients and caregivers trust the systems. It's about the healthcare providers learning to retrust the system and retrust their leadership. We are in the middle of a global workforce crisis in healthcare. I think we all feel that in our day-to-day lives. It's projected that by 2030, we will have a deficit of 18 million healthcare workers. We will have too much work for the workers that we have. This is not just in the United States. This is every single country on this globe. So we will be down 20% of the total capacity that we need to deliver the care as we are delivering it today. And so Mark Britnell is currently working for KPMG, but he's done a lot of work on how can we fix and address this global workforce crisis in healthcare. Everything from government-based interventions to now you see a lot of these intersections with that quality 5.0 agenda. How do we make sure that patients and families are truly our partners? How do we create and capture these communities that these patients live in and let them be part of that care continuum? I'm going to focus in on a couple of these things. Number 6, how do we make sure that professionals are able to function at the top of their game? And how do we start creating these agile learning organizations? Now, this concept of a learning organization is not new. It's quite old. It was kind of advanced initially back by Peter Senge in like 1990. This is quite a bit of a dense book, so I would say, really to kind of delve into this if you want to, but it kind of encompasses 5 major things. It's about having individual experts and then ensuring that they function as an expert team within systems of care that make them able to deliver the quality of care in a safe manner. They need to do that with a shared vision of what their goals actually are and what their role in that is, and shared mental models of how they go about doing things. Now, this all sounds great. It's like a lot of theory, but how do we bring that into actual practice? So this concept has been serially refined. I think the second try was gets a little bit more meaty, starts helping us see what we actually need to do. It's about solving problems systematically and experimenting with new things. Learning from past experiences, now you start seeing these intersections to those reports from the early 2010s. Learning from others, but being able to transfer that knowledge. But we're still not getting quite to this. We're still a bit embedded in this high philosophy and grand themes, getting down to these gritty details of practice on the day-to-day. I think this is the closest that we may get and the closest we've gotten so far. It's about creating these supportive learning environments based on psychological safety and appreciation of differences with openness to new ideas, but then backing them up with these true concrete processes and practices. It's not just about experimentation, but doing it in a meaningful and guided way, gathering that analysis and interpreting that data to know where we need to go in the future, and then educating people and training them in order to be able to adapt to these new processes. And leadership needs to enforce this continual learning cycle, actively questioning and listening to people, creating forums for dialogue and debate, and exemplifying active reasoning. But really, how can we do this? So here I'd like to show you some examples of programs that can serve as building blocks to creating these learning organizations. Building block number 1 is thinking about our organization and how it's designed. So thinking about the structure, we need to think about and do a refresh of what are people's actual roles and responsibilities? What are the reporting lines and do they make sense anymore? Do we have the right workforce with the right talents for current medicine? Do they have the mindsets that we need to do things in the modern era? And have we given them the skill sets and the tool sets to work in this modern healthcare world? And do we have processes in place, and are we constantly improving the processes so they can do what they are uniquely able and skilled to do? Particular things to look out for. There is this concept of feather bedding, which means people actually create work for themselves to justify their existence. And so when you actually look at some people's job descriptions, they've created their own work so that they still have their job. That's okay, but we need to make sure that that is work that actually still needs to be done. Then there's this concept of middle bloat, where There's been a lot of amplification of kind of that middle management structure, so that now what you're doing is you're just creating more steps between people doing the frontline work and the people that control the resources that should enable them to do that frontline work. And so what I would say is we need to have a structure that mirrors the system that we currently operate in. We don't operate in just a complicated system. A complicated system is one in which there's lots of components and lots of connections, but you can decompose that. And if I understand each component, I can then put it back together, and I know things are going to work in a predictable way. And these things aren't necessarily interdependent. That is not the world that we work in. Healthcare is actually a complex system, and it's widely recognized that healthcare is probably the most complex system in the world. This means that it's not about understanding each individual component, because when you put them all together, they act in ways that you cannot predict. And events happen, they emerge, is what it's called, in ways that you can't necessarily prepare for, but you need to be able to be adaptable in order to respond to things in that way. It's also highly interconnected, so you can't change one thing without changing 50 other things at the same time. And so what I'd say is our organizational structure needs to mirror that and be able to respond to the new environment in which we work. Now, this is one way of kind of conceptualizing a different way of working and organizing our teams. It's called a team of teams. So how do we take this traditional top-down structure? I think if you envision the organizational chart in which we currently function, it's gonna look like that top left-hand corner. So connections that matter most in this are connections between the workers and their immediate superior. If we can create things a little bit differently and operate differently, then you start creating these smaller teams that can function independently to address the problems that they see in their day-to-day work. But it's still within a bit of this more rigid superstructure. The goal eventually is that we create these small teams and they can function independently, but function as a highly performing team, but maintain those connections to each individual team. And that connection can resemble the connection that you have between individuals that allow for that work to be done. So really, this is something that's being done not just in healthcare, but in other industries as well. And it's about creating this network of teams. It's all about the structure in which you maintain control of the average number of connections per person. No one can have 200 best friends. The highest functioning teams, typically about 5 to 7 people. Usually once you get higher than that, each additional person actually sometimes takes away from the functioning of that team. But then you also want to pay attention to the mean distance between people. It's that 7 degrees of separation from, what is it, Kevin Bacon, I think. You want to maintain 3 to 4 degrees of separation between these teams of teams, that then when they need to work closely together, they actually have the pathways to work closely with each other. And it's because we work in a situation that the way we used to work together those old rules don't even apply anymore. We need to meet the complexity of the system that we work with now being able to adapt to things on the fly. Things are happening and changing much more quickly. So these teams need to be enabled with what's called empowered execution. You don't need to check up 5 layers to ask if you can do something, because just the time that it takes to check in with that super high boss to see if you can do something means you're not doing things as quickly as you need to. This interdependence needs to be matched with what's called shared consciousness. These are those mental models that define that learning healthcare system, that we kind of understand how we interact together and how we do things as a team. And it all needs to be based on trust in each other and a shared sense of common purpose. So that's that vision of that high-performing organization. And to do that, leaders need to lead differently. It's no longer about that chess match that we oftentimes say expert leaders play. If you think about it, chess matches are with pawns and other pieces that always respond in certain ways. That's not the system that we live in, and that's not how you're going to get the best out of your team. Leaders have to change to be more like a gardener. You need to create the soil and create an environment in which your team can grow and blossom to do what you know that they can do. Going on to a second building block. I know a lot of people know what debriefing is. So the gentleman on the right is S.L.A. Marshall. Yes, he was called Slam, which I'm not sure that that's a great nickname, but he is widely thought to be the first person to advance debriefing. He was an Army historian and would go into the battlefield and talk to soldiers after they came back from the field and debrief them to establish what the truth is. Now, fast forward about 70 years or so, and debriefing is rampant. It's used in a wide variety of industries, including healthcare. And there are some major types of debriefs, including what's called a process sequential debrief. In healthcare, we often think about debriefing in terms of simulation and learning. This is usually more in the realm of a process sequential debrief. But there's psychological debriefs, there's agile retrospectives, which are gamified debriefs that are used in software. And really what I want us to focus in on are kind of the highest quality debriefs that are used in high performance organizations, which is objectives focused and methodology based debriefs. An example of this kind of a debrief was actually a program that was started by two first-year pediatric residents in Toronto. And it's called ACE, which is an acute critical event debriefing. They started this program with the concept of, well, wouldn't it be nice if there is a way that frontline teams could assess their performance in these critical events, a way that we could improve safety, and a way that we can empower and capture the voices of our frontline workers? And so this ACE debrief occurs right after acute event, and it's based off of something called a hot wash, which is used in the US Army after soldiers come back from a mission, and they gather immediately after they get back to talk about four important questions. What did we think was going to happen? What actually happened? So establishing the truth. What went well and why? And what could we do better next time and how? It's been shown that this simple act of debriefing your team can improve performance by 20 to 25%. And so with these two first-year residents over the span of their 3-year, 4-year residency, we created this system and created a tool, which is a tool that enabled these frontline teams to debrief in the moment. It blended multiple formats, but I think importantly, enabled high quality debriefs for people that were not trained in how to conduct a debrief. It was adaptable to many different environments and could be done in less than 10 minutes. It was part of what we call the triple review process, where you did this initial debrief with the team at the bedside, captured their voices, addressed safety threats that needed to be addressed immediately, but then kind of focused it up into a monthly cold debrief where you talked about performance as a whole. And that's where you brought people to the table that could put higher order processes and interventions in place to address those safety threats. We started putting this for our third review kind of category into our safety event reporting system. This then allowed us to create a database and dashboards so that each individual group could understand their performance at a unit level, but then leaders at an organizational level understood performance of the organization as a whole and could see evolving safety threats that wouldn't necessarily be identified if we just looked at things at a unit level. This is a series of implementations. We started out with hospital code blues with pediatric residents running these debriefs. And over the span of about 5 years, created a process that was the standard of care for the entire hospital for every color code. It was even used when we underwent a cyber attack by Russians. This is how they actually debriefed the response to that cyber attack. So we've, over about a decade, it's spanned beyond the hospital to then multiple organizations in the Greater Toronto Area, and currently is being implemented and used on every single continent, yes, including Antarctica at the McMurdo Station for the National Science Foundation. The lessons that we've learned from now literally thousands of events that have been debriefed are kind of exemplified here. You need champions and process owners, but you need to show teams how this can help them address their own local issues. This is how you get people to implement the process. You have to pay attention to that local culture and the degree of psychological safety that team has. You must be driven by data and fastidious in your planning, but you have to respond and be flexible during that implementation. Using that tool really helps, and you need to tailor the process to the environment that you're in. But you also need to tell people what you've done and have people celebrate those wins early so that they see the effects of these debriefs. Now, a counterpoint to that, the second part of this review process is what's called a cold debrief, or maybe a lukewarm debrief. An example of this is performance rounds, which again was something that we started doing at Sick Kids. Performance rounds are a structured cold performance debrief in which we reviewed as a team every single patient that we did surgery on. This was an interprofessional multidisciplinary team, and it occurred 3 times a month with the stated aims of reviewing blameless but accountable work in multiple phases of the hospital course, facilitating team learning but identifying major items to be improved, and then closing the loop on this patient's course. Over the span of about 13 years, over 10,000 patient courses were reviewed and over 400 sessions were conducted. Here you see the evolution of the infographic that supported these debriefs, the tools that supported these debriefs. You can see it evolved from a simple yes, no, did we do the right thing, all the way up through this concept of a flight plan and this visualization of the patient course on the upper right-hand side, and then bringing in data to show how the team performed against standardized norms. So what we discussed was actually a little bit of everything. We talked about performance of individuals, teams, and systems, and then getting back to this concept of not just learning from when things didn't go well, but we actually talked about when things went really well and how could we make that happen again. We talked about all phases of care, and we talked about, in particular, significant residual lesions for our patients that affected those care. Now, I think this was the really powerful thing. We actually polled people. These events would be attended by about 50 to 60 people every week. So massive, significant time investment by this team. Now, I've highlighted with the arrows what I think are the really important things about these debrief discussions. The vast majority of people that attended found them helpful, and most people actually used insights that they gleaned from these discussions to improve their decision-making going forward. The number one thing that people took away, we had a little box in this survey that said, what do you think the best thing is about performance rounds? We wanted to make people fill it in and instead of giving in the defaults. And resoundingly, the number one thing that people said, the value that came out of these rounds was the culture. It was a culture of psychological safety and a culture in which a team got together to talk about performance in an accountable way, but in a way that was forward-thinking and captured what we did well and what we could do better next time. It was also a very effective way to show new members what the culture was and integrate them into that culture in a fairly seamless fashion. Now getting back to a third building block, which is how do we help this struggling workforce function at the top of their game? It's a bit disheartening, I would say, this survey, that the vast majority of frontline care providers are delivering care for which they are overskilled. They are doing things that are distracting them from what they should be able to do. So 76% of physicians and 79% of nurses. This, not surprisingly, contributes to burnout and stress. And I want to make it very clear, we're not talking about making people function at the top of your capacity at all times, because that is how you're going to burn out, and that is how you're going to start making mistakes. So how do we help people function at the top of their game? So sometimes it is good to be gross. GROSS is a program that started in Hawaii at Kapiolani, and it stands for Getting Rid of Stupid Stuff. This is a structured organizational process for capturing the stupid things that frontline providers have to do every day. These are the unnecessary burdens that people have to go through that prevent them from delivering that care. And you can see the process behind the scenes. They rolled this process out back in 2016. And it was a simple form where people said, you know what, in my role as nurse, physician, pharmacist, fill in the blank, if I didn't have to do X, I could do this instead. A team behind the scenes would triage this, and you could see there were certain things that, you know what, this just really was stupid. Examples were things like, you know what, nurses were expected to chart cord care, umbilical cord care for patients that were 30 years old. That just doesn't make sense. That truly is just stupid. Now you're like, whatever, it's a click, who cares? But you amplify that by the number of clicks that had to happen in a given day across an entire healthcare system. It equated to 1,700 nursing hours per month. Massive waste of time. So the first year, there were 200 suggestions. The third year, there were 300 suggestions. 10% of those were just do it suggestions. And then a lot of them fell into this middle group of there were opportunities that needed a little bit more effort, but there's an ability to redesign the care. Now, a lot of these suggestions are EHR focused, but as this program has kind of spread, Cleveland Clinic, Mount Sinai, Children's Hospital Philadelphia have all adopted this program. It's now worked its way into an American Medical Association best practice as a way to relieve these daily care burdens from frontline providers, to decrease burnout and reconnect us to the work that we know we need to do. So this is what Grow Stanford might look like. We're at the very, very early stages. There's a wonderful interprofessional team in the cardiac ICU and CV surgery that's starting to think about what this could look like in our local level. And so this is kind of a prelude to what Grow Stanford might look like. Spans from education through how do we not just get these suggestions submitted, but the key thing that we learned from talking to all these other organizations is there needs to be that acknowledgement that, you know what, I've heard what you submitted and we're going to try and do something about it. It's one of the gaps in some of our other reporting systems that people put something into a system and it's like it disappears into the ether. So that customer service and having people be able to see what's happening to their request is essential for adoption and buy-in. We have garnered a lot of organizational support for this all the way up to the C-suite level. So this is a bit of a prelude. I hope that you start hearing more about this. And if other people want to start learning about it, please feel free to reach out to us. But this is part of a much, much, much bigger problem. A sickness that we don't even know is here, that we don't even know that we need to be treating. And it's called addition sickness. We add things all the time and we add them without ever thinking about what should we be taking away. Fascinatingly, the physiologic nature behind this is that we are hardwired to add things. Studies in nature will show this. When you give groups a problem to solve, they're always going to add instead of seeing what they should subtract. It's rewarded in our systems. It's how you get promoted. What have you done instead of what have you not done? The higher you are in the organization, the more blind you are to the problems that you create for other people. There are ways to diagnose this. There are things called good riddance reviews where you can go through and see, you know what emails are being sent that don't need to be sent? What meetings are occurring that don't need to occur? These bundles that we have for our hacks and such, when you have 20 things in a bundle, my bet is some of those things actually don't need to happen. And there are ways to actually treat this. Leaders can think of themselves as editors in chief. How do I create more work for the people that report to me? And then there's games that you can play. There's the rule of halves where you ask someone, I want you to cut out half of the things that you do in a day. It's a shock to them. No one usually does this, but then it does make it easier for them to say, I'm going to cut out a quarter of the things. There's the subtraction game. You actually can train people as well to be subtraction specialists, where they go in and help people take away things that they don't need to do. And it's really more about friction titration. This is advanced by some folks in the Graduate School of Business here, which is we need to make what we do match the degree of difficulty that it needs to have. Not everything should be frictionless and seamless. When you have a high degree of certainty in what needs to be done, when it's routine work, when there's minimal bandwidth of people to do more work, and when you kind of don't need these like super in-depth relationships, you want to remove as much friction as possible. But you do want to make things a little bit sticky sometimes. When it's unclear what the right thing is to do, when you need to do creative work, and when you need to develop these deep, long-lasting relationships, that's when that friction is actually a good thing. So we're going to get back a bit to these meetings that we talked about. How many people's calendars look like this calendar on the right-hand side right now? Yes, actually, yes. When you look at this calendar, raise your hand if you think, oh my God, these inefficient and unproductive meetings are going to prevent me from doing the work. Probably almost everyone. There's this shockingly bad idea, I think, of letting your co-pilot go. Because it's like, oh, you can be in 2 meetings at once. That sounds awful. Now, raise your hand if rather than go to a meeting, you'd rather go to a doctor's appointment. Yeah, I don't think 60% of people would rather go to a doctor's appointment than go to a meeting. I don't think that's actually saying how great doctor's appointments are. I think it's saying how bad meetings are. 25% of people would rather sit in traffic, and 17% of people would rather go to jury duty. The number one way to get people to go to a meeting, we all know it, it's food. Yes. But meetings and inappropriate and ineffective meetings are a massive mistake for an organization. People looked at one organization, and I'd say most of us probably have more than 18 hours a week of standing meetings. These people declined 14% of them, but wanted to decline 30% of them. So reluctantly going to non-critical meetings equated to $25,000 per employee per year. For an organization that has 5,000 employees, that's $125 million a year of wasted time. And just as an FYI, Stanford Health has doubled that number of people. Something to think about. So let's say you've gone through, you've had a subtraction specialist come in, and you've done a meeting reset. So you've taken your calendar from the one on the left to the one on the right. We don't want to eliminate all meetings because in theory, meetings can be a core way that collaboration occurs, and they can be how we get things done. But if these meetings are broken, much of our collaboration is broken and important things don't get done. In fact, the vast majority of leaders feel that collaboration and meetings actually need to be improved. So what if you could take a meeting in which you constantly go off topic, and that implies there are topics to start with. Meetings that are kind of ships without captains, meetings in which it's the same voices every single time, over and over again, in which you don't reach a decision ever, you just decide to have another meeting, and in which you then create meeting overload. What if you could create meetings that unlock the potentials in you, that actually help you solve problems and make tough decisions, build community and capture all of the amazing things and the people sitting around the table, and have you innovate faster and more effectively? When it's really, really important, a way that you can do these things is to separate out the process from the people sitting at the table, and bringing in people that are experts in this collaboration process, freeing up the subject matter experts at the table to focus on the problems and the solutions at hand. What trained facilitators do is they allow full participation, not just the quick, not just the vocal. They facilitate mutual understanding. Everyone at that table probably has a little piece of the puzzle that put together creates that truth. They then help create inclusive and hence wise solutions by that team. And in doing that together, there's shared responsibility for implementing that solution. And they do it by understanding and managing group dynamics, maintaining neutrality while actively listening, asking those important questions, and giving clear instructions on what people do. They manage the time for you, they manage the energy for you, and they deal with, I love this term, challenging participants. I think we all know sometimes who these challenging participants are. But they do it with a structured process. They do it in a way that discussions are clearly sequenced. Discussions are then visualized to help the team work through them. Participants oftentimes work alone and then together. And at the end, there's always a commitment. There is always a decision. They oftentimes do this by matching the methodology to where you are. Stanford is like, with the D school is like the home of design thinking. That's not what you want to be doing for every single process that you're going through. So what you want to understand is, where are you in this trajectory? You're trying to understand a problem, develop a solution, or implement something. And then there are a variety of methodologies to take you through and walk that team through to get done what they need to get done. An example of this is kind of in the middle which is this design sprint, which is used at Google. And it's a way to innovate faster and short circuit this cycle of, we have an idea, then we're going to meet, and then we're going to meet again, and then we're going to meet again. And then maybe at some point we're going to launch something, and then we're never going to follow up and know if it's the right thing. This, in the span of 6 to 8 hours for a super sprint, gets from idea to potential solution, testing it, learning from it to reiterate on that idea. It is with this concept of together apart, focusing on getting something tangible rather than just endlessly discussing things, getting started and not worrying about being right that first time. It's structured, it's not just creative. You're going to see on that right-hand side, Post-its, everyone knows the Post-its, everyone sees the voting dots. But I think the real power in this is buried in the bottom left-hand corner of this picture. It's about bringing people to the table who know the problem better than anyone else and making that struggling workforce feel heard. This was a Post-it put up by a frontline nurse who had been with us in the ICU for about 2 years. And this was her big takeaway. She's like, my God, someone's finally listening to us. And so really what we get back to then is what I think the North Star of healthcare is, that I think sometimes we veer away from. Healthcare is about human beings caring for other human beings. It's not about people being cogs in the wheel. It's about that human connection. And so instead of just focusing on the technology, we need to refocus on how we solve problems, how we collaborate, how we make decisions, and how we execute. Because this is where we are right now. There's all of this amazing technology and digitalization, but sometimes it feels like it's a bit at odds with the people and the communities that we serve. There's always going to be this tension here. We need to make sure that things don't shift too far over and that we crowd out the people in the communities. Interestingly, a side fact, that center symbol there that we all associate with medicine, this is the caduceus. It is, this winged two-snake staff of Hermes or Mercury, but it has nothing to do with medicine. It actually symbolizes commerce and trade. The real symbol of medicine is the rod of Asclepius, which only has one snake and doesn't have the wings. So we need to make sure that we don't put commerce and money at the center of what we do. So knowing that we are in a celebration of women in medicine, I just wanted to bring forward some of the founding fathers or founding mothers of medicine. So on that upper left-hand corner, being a pediatric cardiologist, Helen Taussig is really one of the core founders of what pediatric cardiology is. Rebecca Lee Crumpler is the first African-American female physician. She got her degree in the early 1860s, just about a decade after the first female physician got her degree, Elizabeth Blackwell. And I think this quote really kind of hits home, that if society will not admit of women's free development, then society needs to be remodeled. This is also, I think, well said by Florence Nightingale. I don't think she needs to be introduced to anyone, but how little can be done under the spirit of fear. And so this is, I think, what I wanted to kind of leave up as our final kind of infographic. This was designed by a group who really looked at ways that we can help advance careers for women faculty in science and academic medicine. Now, there are parts of this infographic that I'm not super excited about, I have to say, but I think the things on the left-hand side really resonate. So I just want to leave those up as opportunities for ways that we can continue to empower women, but also all sorts of groups within medicine in order to make medicine what we need it to be in the future instead of what it was in the past. So that is the end of my presentation. Thank you so much for all of your attention.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.